In this video, I will try to explain the origin and treatment of hammer toe deformity. This is a very common problem which can accompany hallux valgus. The toes are made up of a series of bones, each of which is called a phalanx, arranged in a row. We have 2 in the big toe and generally 3 in the other toes. There are also anatomical variations. The first phalanx of each toe articulates with a bone located just before it called the metatarsal, shown in red, which is much longer than the phalanges themselves. Each foot has 5 metatarsals, each aligned with the corresponding toe. The 5 metatarsals together make up the part of the foot colored in blue, while the phalanges make up the skeletal part of the toes colored in red. What we describe as a hammer toe is the tendency of the joints to assume this position, as you can see in the diagram, in which there is also contracture of the soft tissues around the joints, in particular the joint capsule, ligaments, and tendons. Hammer toe is caused by an imbalance between the short and long muscles of the toes. In the early stages, this imbalance only causes the toe to bend, which can still be easily corrected, but over time, we are talking about years, it becomes rigid and therefore impossible to correct because the joints stiffen irreparably. Among the most frequent causes of this deformity are rheumatic diseases such as rheumatoid arthritis, degenerative cartilage diseases, neurological diseases, traumatic diseases, or even the results of previous surgery or cortisone injections. In several cases, we see hammer deviation of the second toe due to the progressive lateral deviation of the big toe, commonly known as hallux valgus, which I invite you to watch the related video on this YouTube channel. The symptoms reported by patients are clearly related to the flexed position of the toe, which does not occupy its natural space in the shoe. In hammer toe deformity, there is clearly pressure from the upper part of the shoe on the back of the bent joint of the toe, so the continuous irritation not only causes pain, but also thickening of the skin, which then develops calluses, and, in severe cases, can even lead to the formation of an ulcer, i.e., a hole in the skin. Diagnosing hammer toe is very easy and does not even require X-rays. However, it is generally advisable for the doctor to request simple X-rays taken while standing, i.e., not sitting or lying down, in order to better assess the presence of abnormalities in other joints and bones of the foot. Tests such as magnetic resonance imaging, MRI, ultrasound, or computed tomography, CT, scans are rarely necessary except in exceptional cases. Treatment includes both conservative, i.e., non-surgical, methods and surgery. It should be noted that in most cases of rigid hammer toe with pain and difficulty wearing shoes, it is reasonable to recommend surgery immediately, given the progressive nature of the deformity. Non-surgical methods include wearing wider shoes, possibly removing calluses, but only if performed by a qualified podiatrist, and using splints. There are several splints available on the market, including one that is inserted into the hammer toe, and whose purpose is to try to keep the toe in a position that allows closed shoes to be worn more comfortably. Another simpler type of brace is made of soft silicone that slips onto the toe and is useful for simply reducing rubbing of the toe against the upper part of the shoe, as you can see in the photo on your right. Conservative treatment often does not lead to adequate and stable results over time, so a large proportion of patients are candidates for surgery. The type of surgery varies completely depending on whether the deformity is correctable or whether it has become rigid. If the deformity is still in its early stages, we can try to maintain and preserve the mobility of the toe using various surgical techniques, often in combination with each other. The advantage of operating on a reducible deformity is that a minimally invasive approach can almost always be used. There are several surgical techniques that are often used in various combinations to try to achieve the best result. The surgical procedures in question involve lengthening the extensor tendons, i.e., those that run along the top of the foot, and, if necessary, the flexor tendons, i.e., those that bend the tip of the toe downward. Over time, the severed tendons will form a scar that will join the two stumps, thus restoring much of the toe's movement. Another surgical procedure that I perform very often is minimally invasive osteotomy of the phalanges, which I will explain shortly, and sometimes also osteotomy of the metatarsal necks, which I only perform in cases of pain when bearing weight with associated plantar callosity under the metatarsal heads. In this case, too, the operation is performed using a minimally invasive technique. As we have said, in this case, the surgery can be performed using a minimally invasive technique, i.e., with small incisions in the skin, a few millimeters long, through which I can use a small scalpel to lengthen the joint capsule and the extensor tendons located in the upper part of the toe. And through another incision in the skin on the lower part of the same toe, we also lengthen the flexor tendons. Next, we remove a small slice of bone using a special drill with a diameter of 2 millimeters. Once this small wedge of bone has been removed, the two parts are brought together by applying compression. We repeat the same procedure on the adjacent phalanx, but this time removing the wedge of bone from the top. Again, we apply the same compression at the end to ensure that the finger is properly aligned. The correction obtained is kept stable over the following weeks using a metal wire called a Kirchner wire, which has a diameter of 1.4 millimeters and is inserted from the tip of the finger deep through all the phalanges. Finally, we apply a bandage with special protections on the metal wires protruding from the skin of the finger. If the deformity of the finger is too advanced and rigid, we must necessarily perform a blockage of the interphalangeal joint. This procedure is called arthrodesis and is performed with a cut of about 2 centimeters on the upper surface of the finger. The purpose of the procedure is to fuse the now rigid and arthritic interphalangeal joint in a better position. Once the skin has been incised, we reach the joint where we remove 2 thin slices of bone using a small oscillating saw that allows us to make very precise bone cuts. At this point, we must make a small tunnel inside the bone, i.e., inside each phalanx, with a diameter of 2 millimeters, in order to insert the synthesis devices, which can be metal wires called Kirchner wires or small resorbable nails, i.e., made of a special material that will tend to disappear on its own within 6 to 9 months. In the case of Kirchner wire, however, we will have to remove it after 6 weeks, again without pain and without even the need for local anesthesia. Regardless of the type of surgical technique we use to correct hammer toe, it is almost always possible to put your full weight on the ground immediately, provided you wear shoes with flat, rigid soles, such as those shown in this photo, which you will need to wear for the first 6 weeks. It will be essential to keep your foot elevated to avoid swelling, and it will be important to walk for no more than 15 minutes at a time, several times a day, but avoid standing still, for example while cooking or ironing. After 6 weeks, following a checkup X-ray, you can stop wearing the post-operative shoe and start wearing a normal shoe, provided it is wide and soft at the toe. It is not uncommon for the operated foot to still be swollen at this stage, so it may be advisable to start physiotherapy, especially for lymphatic drainage. The sutures are generally absorbable and therefore do not need to be removed. There is also no difference between the two surgical techniques in terms of anesthesia. In both cases, peripheral anesthesia will be administered by means of an injection performed under ultrasound guidance at the calf level, which allows selective infiltration of the nerve, visualized with ultrasound. The major advantage of this type of anesthesia is not only its low toxicity, but also its excellent coverage of pain after surgery, to the point that many people are surprised that they do not even need to ask for pain medication once they return home. The alternatives to this type of anesthesia are narcosis, i.e., general anesthesia, or spinal anesthesia. As with all surgical procedures, it is important to be aware that there are possible complications, which you should discuss with your surgeon and which are listed below. These include the possibility of persistent swelling, which could make it difficult to wear closed shoes for several months, recurrence of the deformity, which could require further surgery, or residual stiffness in the fingers.